Well, good afternoon, everyone, and welcome to the Thomas and Salma Haider Biomedical Breakthrough Lecture Series. Before we start, I would like to thank Dr. Thomas and Salma Haider for your support to the UCR School of Medicine for over 20 years. You've been with us along the journey even before the inception of the medical school as a four-year medical school. Thank you for your support. We appreciate everything that you do for the school and for our students and the mission of the UCR School of Medicine. Without further ado, I would like to introduce Dr. Deborah Dees, the Dean of UCR School of Medicine.
Thank you so much, Edna, and good afternoon, everyone. Thank you for joining us for this special event. As Edna stated, each year, this lecture brings the best and brightest researchers in the biomedical field to UCR School of Medicine and the Riverside community to present their research. This is the Thomas and Salma Haider Medical Breakthrough Lecture. Every year, I've been excited to hear the presentation, and I'm always enlightened, having learned so much. I'm equally excited this year, and I expect that we will leave the lecture having learned something significant. I would like to take a moment to recognize the planning committee who coordinated this event. Dr. Thomas and Salma Haider, Dr. David Lowe, Distinguished Professor of Biomedical Sciences, Dr. Monica Carson, Chair of the Division of Biomedical Sciences and Professor of Biomedical Sciences, also the S. Sue Johnson Presidential Endowed Chair. She's also chair for the Thomas Haider Program Health Science Committee, which plans this event. And I also thank Ms. Edna Johannes, Executive Director of Development. I'd like to especially thank Dr. and Mrs. Haider for creating the endowed fund that supports this event each year. This event would not be possible without their generous and ongoing support of the School of Medicine. This afternoon, we are lucky to have Dr. Jens Juul Holst here with us. He is taking the time to join us online from Copenhagen to discuss his research. Dr. Holst leads a team at the University of Copenhagen, which studies the endocrine regulation of metabolism. And this afternoon, he will be speaking to us about the gut as a source of effective medication for obesity and diabetes. Thank you all for joining us for what promises to be a truly informative presentation. Before we begin, I'd like to take a moment to introduce Dr. Thomas Haider. Dr. Thomas Haider is a world-renowned spine surgeon, philanthropist, entrepreneur, and inventor, a driving force behind the creation of UCR School of Medicine. Dr. Haider established the Thomas Haider Program at UC Riverside School of Medicine, which provides an avenue for culturally diverse, underprivileged students to enroll in UCR School of Medicine each year. This program stemmed from the earlier UCR-UCLA Thomas Haider Program in Biomedical Sciences. Dr. Haider is a recipient of the UC Riverside Chancellor's Medal of Honor, the American Medical Association's Pride in the Profession Award, and he was awarded the Outstanding Medical Professional of the Year Award by the United States Congress. He developed and patented significant medical instrumentation used in spine surgery throughout the country. He is the founding member of the American College of Spine Surgery, and Dr. Haider, along with his wife Salma, created and operates the Children's Spine Foundation, through which they provide free medical care to children at their clinic, the Haider Spine Center, as well as in hospitals abroad. Dr. Haider has authored numerous medical publications and was appointed by the governor of the state of California to the Medical Board of California, and later to the State Bar Board of Governors. He currently serves as Associate Clinical Professor in UCR School of Medicine, as well as clinical faculty at UCLA School of Medicine. Dr. Haider and Salma have named and endowed the Salma Haider Endowed Chair for the Thomas Haider Program, held by the Executive Associate Dean for Student Affairs, Dr. Danny Teraguchi. Without further ado, I'd like to present Dr. Thomas Haider.
Thank you, Dr. Dees. Thank you for your kind presentation and kind words. Also would like to start by thanking Chancellor Wilcox, Dr. Dees, the Planning Committee, Dr. Monica Carson and Dr. David Lowe, as well as the University Advancement, Edna Johannes. They have been very instrumental in planning this meeting, and without their help, we would not be able to do this. Also would like to congratulate our last year's speaker, Dr. Baker, who was just given the Nobel Prize for his research on protein synthesis. It is my pleasure to introduce Dr. Jens Holst. Dr. Holst is an internationally renowned Danish researcher and physician whose groundbreaking work has transformed our understanding of endocrinology, diabetes, and metabolic diseases. Dr. Holst is widely recognized for his pioneering research on gut hormones and discovery of glucagon-like peptides, GLP-1. That peptide, as we know it now, treats a lot of patients with type 2 diabetes as well as obesity. And I would like to say it has helped a lot of my patients who was fighting with obesity, and that is very common with a lot of patients with lower back problem. Dr. Holst got his medical degree and doctorate degree from University of Copenhagen. He's currently Professor of Biomedical Sciences at the University of Copenhagen. He has published well over 1,000 publications in top-tier medical journals. He has received many accolades, including Novo Nordisk Prize, Claude Bernard Medical, and Paul Langerhans Medal from the medal. He is also a member of the Royal Danish Academy of Sciences. In addition to this, Dr. Holst is known for his dedication to mentoring young scientists. His collaborative approach to research has fostered international partnership and advanced global understanding of metabolic diseases. Dr. Holst, it's an honor to have you as our speaker this year. Thank you for being here.
So thank you very much for this very, very kind introduction. I'm so sorry that I'm not able to be there physically. It was complicated to get there and to make this happen. So, but I'm happy that it's possible to do this via Zoom. So yes, you're right. I'm supposed to talk about the gut as the source for effective medication of obesity and diabetes. So let's move on with the first slide and start back where I started in the beginning of the 1970s when I was training in surgery, and we were dealing with surgery for duodenal ulcer disease, and some of our patients developed reactive hypoglycemia after the operation, postprandial hypoglycemia, as you can see here. And this was clearly because of too much stimulation of insulin secretion. So the problem came up, and that was really the question we were asking: could this be an effect of the incretin hormones? And the incretin effect had just been discovered, and it had been demonstrated that you had a larger insulin response when, for instance, glucose was put in the gut here, as opposed to intravenously. So here clearly demonstrating the effect on insulin secretion, and this was the first paper of the kind. But the problem was that nobody knew which hormone it would be. So here's a list of the hormones, of the gut hormones. And as you can see, something happens around 1970. And that's when Victor Muth started working in Stockholm and pulling out peptides from porcine intestine. And some of the interesting peptides that he pulled out was gastric inhibitory polypeptide, for instance. And let's have a look at that. That's in 1970. Here we have it, gastric inhibitory polypeptide. Could this be one of them? And this was tested for insulin secretion by John Brown from Canada. And you can see here, when he infused rather impure, I must say, porcine GIP to people, he would have a great stimulation of insulin secretion here as compared to placebo here. And in spite of that, the glucose levels were falling. So this could be an incretin hormone of interest. But we felt that there had to be another incretin hormone. We were working with GIP, and immunoneutralization could not remove all the incretin activity in plasma. This was demonstrated by us and people in Germany. And we had a particularly interesting case here where we were looking at people with intestinal resections. And there the incretin effect did not correlate with GIP secretion, but with the lengths of the distal small intestine still in situ in continuation. So something had to come from the distal small intestine to explain the incretin effect. Then further things that happened was that we could show that GIP did not stimulate insulin secretion in patients with type 2 diabetes, which was actually a great disappointment. And the incretin effect was even lost in people with type 2 diabetes. This was shown by Michael Nauk in 1986. So the enthusiasm for this mechanism was really, really low at the time. Okay, so we were looking at these cells in the gut. This is a human gut, and we have these cells that are lighting up in the crypts of the gut here, and that's because we have been staining them with an antibody against glucagon. Now, glucagon is, of course, they're not supposed to be in the gut, but nevertheless, the antibodies would see these peptides or these cells here in the mucosa, and it was known that glucagon could actually stimulate insulin secretion. So could it be? And you know, if you inject glucagon into people, yes, you know that the glucose will rise, but you will also have a very strong insulin secretion. So this could be a potential candidate. So the problem was to find out what was in these cells. And so we were looking at different sorts of antibodies against glucagon. And it turned out that they fall in two categories. Some that will react in a radioimmunoassay setting with extracts from the gut, clearly would see these cells, and some that would not, that only would react with glucagon from the pancreas. So clearly there were two different ones. And if you use them for radioimmunoassays, what you would see is that those that were cross-reacting with the extracts, they would show a big rise after a meal, as shown here, whereas those that were specific for the pancreatic glucagon, they would show a decrease. So obviously something was completely different with this compound from the gut. So the interesting thing was to find out what was it. And we proposed that this increased secretion of gut glucagon, that's what we called it, could be explaining the reactive hypoglycemia in our surgical patients. And here you see some of them with the reactive hypoglycemia, certainly, the hyperinsulinemia, and also the high secretion of this gut material that you could measure in this way. But what was it? So it took about, now we are up in the early 1980s. It took some time to find out what it was. It turned out to be this molecule of 69 amino acids, which today is called glycentin. And glycentin has the entire glucagon sequence in the middle of it here, as you can see here. And that, of course, explained why this molecule would react with the glucagon antibodies. But we could also find these bits and pieces in the pancreas, not only in the gut. So we proposed that this peptide indeed was a pro-glucagon, the precursor of glucagon, which then would be formed in the pancreas and in the gut, and in the pancreas give rise to glucagon, whereas in the gut it would give rise to this glycentin peptide instead. There was one problem, though. That was that several studies, also from our own laboratories, demonstrated that pro-glucagon had to be larger than glycentin. Glycentin was 69 amino acids, corresponding to some 9,000 or something like that. But the molecular weight, the proposed molecular weight of pro-glucagon would be up to 18,000. So it had to be bigger. And Patzel from Don Steiner's laboratory was able to isolate a fragment from the pancreas that was of 10,000 molecular size, but did not contain glucagon. So if that was also derived from pro-glucagon, it had to be very big. So what was in the rest of pro-glucagon? And the breakthrough here came from Chicago. Again, this was Graham Bell, who was a professional cloner. He was the molecular biologist who really could do this. And he managed to deduce the structure or to clone the cDNA of pre-pro-glucagon from hamsters. He got 400 hamsters from Eli Lilly, so that helped, of course, a bit. And he then had the structure of the pro-glucagon as you could deduce it from these mRNA sequences from hamsters. And you can see the glycentin sequences here. So that was correct. It is a part of pro-glucagon. It was all right. We have the glucagon in the middle, so it was this. But in addition to that, there were stretches. There were glucagon-like. There was a first stretch, a glucagon-like peptide 1 sequence, and a glucagon-like peptide 2 sequence. And this was, of course, hugely interesting. So what we did was to synthesize those peptides and create radioimmunoassays. This was a specialty of the laboratory. We could create new radioimmunoassays in just a few months. So we did that for both assays for both GLP-1 and GLP-2. And then we started to look for, these are the antibodies, and then we started to look for the actions and the secretion. So we started to see, where are they? Are they formed at all these GLP sequences? So we looked at extracts from the pancreas. Here we have my favorite tool, which is an isolated perfused porcine pancreas, a technology we made for pancreas transplantation, of course. But this is the model. So we could look at secretion of these new peptides from the pancreas, for instance. And we could also look at secretion from an isolated perfused intestine that we also prepared, so that we could look at both of these sites. And then we could look at the extracts and do chromatography, determine the size of the molecules. And here we could look at the pancreas, and we found that the immunoreactivity measured by us for GLP-1 was present in a large molecule with a molecular size of around maybe 8,000. And GLP-2 was in the same molecule, also a large molecule. Whereas in the gut, there was a much smaller molecule that was reactive with GLP-1, and another one which was reactive with GLP-1, also a smaller molecule. And we could also look at the secretion here, because here we have the pancreas, and we could stimulate the pancreas with arginine that stimulates glucagon secretion, and GLP-1 would come out, and GLP-2 immunoreactivity would come out. We will analyze the molecular size in a minute. In the gut, we could stimulate with glucose in the lumen and see that GLP-1 came out, and GLP-2 came out with this glucose, and also with bombesin, by the way. And we could do the chromatography, and here we have it again, the GLP-1 in the pancreas, one single large molecule with both GLP-1 and GLP-2 in it, whereas from the gut, the secreted material was the small molecule, the GLP-1, and the small molecule, GLP-2, separately. So the point was that the processing appeared in our hands to look like this. Here we have the precursor again. And in the gut, it would be processed to produce glycentin, and then a GLP-1 and a GLP-2. Whereas in the pancreas, we would have glucagon being formed, and then this big peptide, the major pro-glucagon fragment, which did not contain glucagon, but had both the GLP-1 and the GLP-2 sequence buried somewhere in the middle. Now the question came up, what about the actions of these peptides? So now we had them synthesized, so we could look at their effects. And we did. And we looked at it again on the isolated perfused pancreas, which really can produce a lot of insulin, but there was absolutely no effect of GLP-1 and there was no effect of GLP-2. That was, of course, a huge disappointment. But what we did instead was say, oh, let's go for the natural peptide. Rather than make these stupid predictions, rather than trying to predict what is happening, let's go for it. Let's extract it. We extract the human and porcine gut, and we did all sorts of, we looked with our radioimmunoassays and did all sorts of chromatographies, and were able to purify them sufficiently to sequence the peptides and test the effect of these purified peptides on the perfused pancreas. And that's what we did. So here we have the result of the GLP-1 on the pancreas again. And now you can see that we have a peptide that very powerfully stimulates insulin secretion. So this was the real GLP-1, the natural GLP-1, not the predicted synthetic one, but the natural GLP-1 could do this. And we published this already in 1986. So eventually we could map precisely all of the real products of proglucagon. And here you see the GLP-1, compared to the predicted one, was truncated by 6 amino acids and was amidated in the C-terminus, and GLP-1 was also slightly different. These are the real molecules that came out, and here we have again glycine and glucagon, of course. So we could look at the effects of it in detail, and we could show that GLP-1, yes, would stimulate insulin secretion, and that the secretion would depend on the glucose levels. So if there was no glucose, it wouldn't do anything. If there was normal glucose, it would stimulate, and the higher glucose levels were, the more insulin would come out. And this was, of course, as predicted from an incretin hormone, but it was not really interesting because GIP had done the same and it was not doing anything. And there were other peptides from the gut from Stockholm that also stimulated insulin secretion. So it was not that interesting. But the next study was interesting. This is where we look at glucagon secretion. And you can see that glucagon secretion was powerfully inhibited by GLP-1 in very low concentration. This was interesting because none of the other peptides did that. And if you look at the two hormones, one hormone, insulin, brings down the glucose levels by deposition of glucose in tissues and the liver. The other hormone, glucagon here, it promotes the plasma glucose by producing glucose from the liver. So if you can stimulate insulin and inhibit glucagon, you will have a double mechanism for lowering blood glucose. And that was, of course, hugely interesting. So we looked at that in people, healthy individuals here, and infused them with absolutely physiological levels of GLP-1, and then looked at glucagon, and you can see that glucagon was suppressed, and looked at insulin, and you can see that it was stimulated. And as a result of those two changes, the hepatic glucose production here decreased by about 30%. And as a consequence of that, we had a decrease in plasma glucose, but not very much, just about 1 millimoles. And as you remember, the effects of the hormones were dependent on glucose. So once you get to this level, it doesn't work on insulin any longer. That could also be seen. So it limits itself. And that's why you cannot produce hypoglycemia with these peptides. But that's how they work. So let's come back to the reactive hypoglycemia of our surgical patients. Much later, we were able to study this in detail because a blocker of the GLP-1 receptor, exendin 9 to 39, was now available. So here we have the patients, the glucose levels. You can see the reactive hypoglycemia. And then we could treat them with a blocker of the GLP-1 receptor, and you can see that we could completely prevent the hypoglycemia. And this is true also for insulin. This was before. This is the ORY patients actually having a large response of insulin here, and then the blocker of GLP-1 here, and you can see that now we can completely normalize the insulin response. So this was indeed due to GLP-1 as we predicted. It took 20 years to find that out, but nevertheless, it was true. So here we have a new incretin hormone. And you get a new hormone and you start asking yourself, is that all that it does? Is it only insulin secretion? And now it was also glucagon secretion, which was interesting. Can it do anything else? So we started looking at GI functions. So first of all, we looked at gastric emptying, which is important for glucose. And we found that it very profoundly inhibited gastric emptying. So this is what you see with GLP-1. And we also looked at acid secretion because this was the time of duodenal ulcer disease, so this was interesting. And here you can see that it very profoundly inhibits acid secretion. And this is interesting because this is a sham feeding experiment where the acid secretion is stimulated by a vagal that is a cerebral stimulus, and the sham feeding here, and it's very powerfully inhibited by the GLP-1. So the next step, of course, was to move on to say, what else can it do? What else do these peptides from the gut do? And it was proposed already in 1973 that cholecystokinin might inhibit food intake. So it was natural for us to go on with that and look for it. So here we infused people with physiological levels of GLP-1, and you can see that you could stimulate satiety, increase satiety, and decrease hunger. And as a result of that, in an ad libitum meal situation, we had a decrease in food intake. So this was a physiological effect of GLP-1 that all of a sudden appeared here. I'm sorry, here. So the next thing that happened was then that we were able to collect a number of studies, both from our own laboratory and from other studies where people had been looking at infusions of GLP-1 and the reduction in food intake. And as you can see, there's a very nice relationship here, which means that the more GLP-1 you could give them, the more you would inhibit food intake. And this turns out to be important today, really, really important. So you could ask, is it a physiological action of GLP-1? Yes, it is, because we can block the GLP-1 effect with exendin 9, as I suggested. And you can see that if you do that, then people start to eat more, suggesting that GLP-1 had been inhibiting the food intake. If you take it away, they eat more. How does it do that? Could it be an effect of the stomach? People were proposing that, of course, because there are these effects on the stomach, but a lot of experiments indicated that this was probably not the mechanism. Instead, there could be interaction with sensory vagal afferents, as suggested by the sham feeding experiment. And there could also be central effects. Let's look at the vagal afferents first. So here we have the GLP-1 cell in a crypt in humans. And you can see it lighting up here with antibodies. And outside here, you can see a red structure. That's a capillary. And it's stained against an enzyme, which is called dipeptidyl peptidase 4, DPP4. And what does that do? Well, it cleaves the molecule, the GLP-1 molecule here. And the metabolite here is inactive in terms of insulin secretion. So it's ruined the peptide. And this happens incredibly fast, so that GLP-1 has a half-life in the body of around 1 to 2 minutes in people. And it also is cleared by the kidneys extremely efficiently. So there are two major mechanisms here getting rid of GLP-1 extremely fast. So how's that possible? How can it act then? Well, what may happen is, if you look at a villus here, you see the L cell that produces GLP-1. This is GLP-1 diffusing across the lamina propria. It finds a capillary where we have the DPP4 in the endothelium. It ruins the peptide, so now there's only a quarter left in the intact active form. Then it arrives at the liver, but there's also DPP4 in the liver. So now about half is removed, and now we're down to about only 12%. And there's also a circulating form of DPP4 that will ruin some of the rest. So very, very little actually ends up at the pancreas or the stomach and other organs. But on its way here, from the cell to the circulation, it can interact with sensory afferents of the vagal system and also enteric nervous system. And these nerves, they do express the GLP-1 receptor. Their ganglions sit here in the nodose ganglion, and they then send ramifications to the nucleus of the solitary tract up here. And from here, these neurons can then signal to the dorsal motor nuclei of the vagus and exert the activities of the gut and of the pancreas, or they can signal to the brain and to the hypothalamus and carry out the signaling up there. Can this be, can this be demonstrated in people? And we thought, yeah, let's try it. Let's try the usual old tricks and look at people that had truncal vagotomies. We could find some patients that had truncal vagotomies, so we were looking at them. And here we are looking at, a control experiment where we are looking at pancreatic polypeptide response. Pancreatic polypeptide comes from the pancreas, and it seems that there is a cholinergic nerve fiber from the vagus in each of these cells. So it's a very sensitive measure of vagal activity. And here we have the controls, and you can see that they have a meal response here. And then if we give them GLP-1, we can almost completely abolish that response. So that again suggests that, you know, the powerful action on the vagal nerve. And then we have the vagotomized individuals here. And you can see they have a nice response, PP response, but there's absolutely no effect of GLP-1 after the vagotomy. So if we then look at food intake, here we have the controls with a normal suppression of food intake, as we would expect when we give them GLP-1, whereas in those with a vagotomy, there's absolutely no effect on food intake. All of this, of course, very strongly supports the vagal mechanism of action, and that has been supported now by numerous other experiments, mainly in rodents, of course. But there is also another way, and that is the central effects. And actually, GLP-1 may directly access the central nervous system via the circumventricular organs. So we found out that by simply injecting radioactive GLP-1 into rats and look for where it went. So if we looked at the brain, we would see it here in the subfornical organ and also in the area postrema. These are the leaks in the blood-brain barrier, the circumventricular organs, where the brain can talk to the periphery. And that's exactly where GLP-1 goes and starts its signaling in the brain. And if you look at the activity of those neurons, then you can measure C-FOS, and this was done here. And again, this is before and this is after. In this case, it was liraglutide, the long-acting one. And you can see how the cells are excited in the area postrema, but also actually in the nucleus of the solitary tract. And you can also see signaling in amygdala, which is interesting, and in the hypothalamus in several of the nuclei. So this is a beautiful slide that I borrowed from Novo Nordisk, where they're showing what happens to semaglutide, where it goes. First of all, this is where labeled GLP-1 goes in the rat brain or the mouse brain here. And to the right, you can see what cells are being activated here. And those are the ones that light up, that light up here with the C-FOS, when they are when they are activated by the contact that GLP-1 has made over here. So this is how it works on the brain. And that means that there's a difference between the endogenous physiological GLP-1, which mainly acts via the vagal afferents here and hits the brain and exerts its activities. At high concentrations, if it's very strongly stimulated, the circulating concentrations may be high enough so that it can also reach the brain via the vascular route, and for instance, the area postrema and the subfornical organ here and the median eminence. But when you inject a GLP-1 receptor agonist, it will mainly act via the circulation. It will not so much interact with the vagal pathway, but it will hit the circulation in high concentrations and get its way to the brain in this way. So there's a difference between the endogenous and the exogenous GLP-1. Now, after some time, we were standing there with a peptide. We could look at its actions and we could compare it with the type 2 diabetic phenotype. And these have, of course, impaired beta cell function. And what GLP-1 could do was to improve beta cell function, almost any aspect of it. You would have reduced beta cell mass, and GLP-1 appeared to reduce beta cell apoptosis and protect beta cells. You would have glucagon hypersecretion, and GLP-1 could inhibit it. You would have overeating and obesity, and GLP-1 could inhibit the overeating. I'll come back to the macro and microvascular complications in a minute. And you would have insulin resistance, and you can also improve that during therapy, although it's probably mainly because of the actions on the body weight. So all of this meant that we had to look at the effects in people with type 2 diabetes, and that's what we did together with Michael Nauk in Göttingen. And we infused people with rather severe type 2 diabetes that were admitted to hospital to get insulin. But we gave them an infusion of GLP-1 for 4 hours at this rate here. And you can see that it was possible to bring glucose levels completely down to normal fasting levels. And this happened as you stimulated insulin secretion and as you inhibited glucagon secretion. So this was a real breakthrough. This was where it was demonstrated seriously that you could treat diabetes with a GLP-1. And then Mette Sander in our laboratory here did a heroic study where she continuously infused subcutaneously GLP-1 into patients with type 2 diabetes for 6 weeks using insulin pumps. And she had fantastic results in that study, major reductions in plasma glucose, reductions in A1C by 1.3% in 6 weeks. She had a weight loss, a significant weight loss, improved insulin sensitivity, enhanced beta cell function, and no side effects. So this was proof that it was not only an acute action of GLP-1, but it could also be maintained and used chronically. So how do we translate this into clinical medicine? So the problem, as I indicated, was this enzyme that destroys the GLP-1 molecule. So you'll have to think of some way of stabilizing the peptide for that. And you can do that by exchanging amino acid number 2. So out of that came a number of analogs that are all more or less stabilized against this DPP-4. And some other peptides were not cleared as quickly from the kidneys as the natural GLP-1. Exenatide is one example, lixisenatide is another one, but they're short-acting, and I'll show you why this is perhaps not a good idea. The other ones here are protected from the renal elimination by binding to albumin because there's a fatty acid attached to the molecule, and this is the first generation, this is the second generation, I'll come back to that. Dulaglutide is a large molecule with an Fc fragment bound to it, thereby preventing renal elimination. And tirzepatide is a very special case that I'll come back to in a minute. But it is a GLP-1 receptor agonist, in fact. So here comes the next really interesting finding. The finding is that it also gives cardiovascular protection. And here you can see that this is a study with semaglutide where it was used in a cardiovascular outcome trial over a period of 2 years here. And we're looking at MACE, major adverse cardiovascular events, which comprise the cardiovascular deaths, a non-fatal myocardial infarction, non-fatal stroke. And you can see there is a 26% reduction in the occurrence here. And that was, of course, a fantastic sensation that it not only was good for treatment of the hypoglycemia of type 2 diabetes, but also actually would turn up to be beneficial for heart endpoints. And, you know, in trials of in all trials of the GLP-1 receptor agonist, they all result in the same, except for the short-acting ones, where there's no effect on the MACE, as you can see here. But all the other studies with the long-acting GLP-1 agonist, they show this beneficial effects on the cardiovascular system. And if you look in a meta-analysis of where it does it, how it does it, then you can see the overall effect on MACE, but you can see that its myocardial infarction is improved, stroke is improved, cardiovascular mortality is improved, all-cause mortality, fortunately, also, and also heart failure is improved. So these are really interesting findings, of course. And if you look at stroke, because this sticks out as a very important thing here, stroke in people with type 2 diabetes, this is a pooled analysis of studies with semaglutide, you can see that there is a very significant reduction in the risk of stroke while you are on therapy over these couple of years here. To continue along that line, a recent Swedish study followed the development of dementia while people were on therapy with a GLP-1 receptor agonist. And now you can see that there's a very pronounced reduction in the risk, in the rate of appearance of dementia in these studies. So how does it do that? How does it do that? Of course, we've talked about the effects of GLP-1 on the pancreas and the glucose production by the liver, and we've talked about the stomach. But there are also other systems, and that's perhaps what is really important here. One thing is the effects on the blood, on the circulatory system. That's where we have receptors on the endothelial cells. And it seems that you can improve and prevent experimental atherosclerosis with GLP-1 agonist, and that there is a direct effect on the blood vessels on the circulatory system. So this is one way where you can improve the function of the entire body because you hit what is common for all, namely the circulatory system. Another thing is inflammation. So it turns out that treatment with GLP-1 receptor agonist will reduce the levels of inflammatory markers. Obesity and diabetes is associated with increased inflammation, and it probably is one of the reasons for the progression of the complications. But GLP-1 therapy very significantly reduces the levels of the inflammatory markers. So these are some of the very important things. But of course, there is also the weight effect. And let's have a look at that. So how did that come about? Because, in the beginning, yes, there was a small effect. I did show you the effect of physiological levels on food intake, but how has that all of a sudden resulted in a weight loss of up to 25%? Let's have a look. So the first thing that happened was the first agonist here, liraglutide, which did have an effect on body weight, just a few kilograms, but it was nice compared to insulin and sulfonylureas, which would increase it. But it was felt all the time that maybe by increasing the dose, you could obtain more, as we indicated at the beginning. So this was done in a dose response study here, and it was clear that the normal dose gave a nice weight loss, but the higher doses up to 3 milligrams gave a much larger weight loss, and in this case, up to around 8 to 10% of weight loss. And this was the background for a number of clinical studies, the scale trials with 3 milligrams of liraglutide, which eventually meant that there was approval of 3 milligrams of liraglutide for the therapy of obesity. And this was the compound that was named Saxenda. And this really was the first of these compounds that was registered for obesity. It never became a huge success. Some people are happy about it, but it never became a huge success because, after all, 8 to 10% weight loss, is that really important? It did not live up to the expectations of the patients, and it did not necessarily result in major metabolic effects. So what happened then was the next generation of GLP-1 receptor agonists came about. Here is semaglutide. It was improved by further resistance to DPP-4 and by an improved fatty acid binding stronger to albumin, and therefore it now had a half-life of 1 week instead. Very good compound. And so it had a very nice result on weight loss and on glycemic control in control studies in people with diabetes, and weight loss is around 8% or something like that. But again, it was felt that perhaps you could obtain more. And the problem is, of course, always with these agents that if you increase the dose, you also increase the risk of complications, of side effects, of gastrointestinal side effects, nausea and vomiting. But the way to deal with this is to make a very slow up-titration of the dosing, it turned out. So this was done, slow up-titration, and a new dose-response study with semaglutide. So here is the placebo. Here is the Saxenda, the 3 milligram liraglutide. Nice weight loss, 7.8%, as I said. But then with the higher doses of semaglutide, you could obtain much larger weight losses. Now we're up to 14% in 1 year, as indicated here. So clearly you could obtain more. And that resulted then in a phase 3 trial of semaglutide, 2.4 milligrams for body weight loss. And that's what we're called today, the STEP trials. And here we see one of the STEP trials here. And here we're looking at people with obesity, but no diabetes. And you can see in these people over the period of 68 weeks obtained a weight loss of close to 18%. And now we are at a realm where a range of effects here, where the patients are happy, and where the diabetologists can see that the diabetes is very much improved, that the incidence of diabetes about decreases, and that you may even see almost normal levels of hemoglobin A1C. So this was a huge difference. And of course, if you look at the competitor, the tirzepatide molecule, it's even stronger, has even stronger effects on body weight here in the SURMOUNT-4 trial, which is also a trial in people with obesity but no diabetes. You can see there is an effect over 88 weeks of 26% of body weight loss, which is really huge. So is this important, you can ask? And this was investigated in the SELECT trial, which is really one of the big landmark trials of this. Semaglutide was looked at for the risk of major adverse cardiovascular events in 17,600 people, followed for almost 4 years. And there was a reduction of these major adverse cardiovascular events by 20% in that study. And this indicates, of course, that you can prevent the disastrous complications, not only of diabetes, but also the risks of obesity. Here's another super important study, the FLOW trial, where people with chronic kidney disease were looked at, type 2 diabetes and chronic kidney disease. 3,500 patients again. And this resulted over several years in a reduction in the endpoint of 24%. That was kidney disease progression and cardiovascular and kidney deaths. So really a remarkable finding. And if you look at the detailed results of it, you have all the risk reductions in kidney function and also in cardiovascular functions. But I'd like you to look at this particular function, that is kidney function. That is kidney function as glomerular filtration rate, which is the appropriate measure. And in these patients, you see a decrease, a yearly decrease here, steep decrease in kidney function over time. But during the therapy with semaglutide, you can improve that with a GLP-1 receptor. You can improve that. You can slow down the rate of decrease. So I think this is a very, very important observation. Also, these cardiovascular outcome trials and this trial, also all of them documented that the serious adverse events observed during the trials were significantly less during therapy. And this, of course, is consistent with what I've said, that you reduce the risk of these major complications, of course, but you do see that what we normally register as serious adverse events is reduced during therapy. So another interesting effect of the GLP-1s is their effect on the reward system in the brain, because this is really the details of the mechanism of action on the food intake. It inhibits the reward effect. And that means that you can, if you view food intake as a kind of abuse, it suggests that you could also treat other cases of abuse by reducing the reward effect. And that's exactly what you see. So here's a study where the use of association with incidence recurrence of alcohol use disorder was studied in a huge group of 80,000 individuals. And here there was a reduction by 50% of the problems with alcohol use disorders in this material. And the same is true for this study, cannabis use disorder. Again, same large group of 85,000 individuals, and there was a reduction by almost 50% in the incidence of these cannabis use disorders during the, and that's an effect of the reward system. So I'm coming to the conclusion now. My conclusion is that GLP-1 is an important incretin hormone. It has effects on both food intake and appetite. It acts via afferent neurons and the CNS. The GLP-1 agonists are effective anti-diabetic drugs. I've shown you that. GLP-1 has protective effects on the cardiovascular system and offers renal and neuroprotection. And that's why, of course, I think that everybody can understand that we're now in a completely new situation where we can do radical changes in the treatment of both obesity and diabetes. And this is what we are dealing with now, trying to put this into general practice. So I thank you very much for your attention. Thank you.
I just thank you for such a wonderful presentation that has really clarified a very complex set of subjects. And so at this time, what I'm going to do is I'm going to invite everybody to use the Q&A format. And also, Dr. Lowe, I'm going to introduce Dr. David Lowe, our Distinguished Professor of Biomedical Sciences. He's serving as the moderator, and I think he will also be taking some live questions as well. Dr. Lowe?
Hey, thank you. Dr. Holst, thank you for an outstanding presentation. So what I'm going to do is I'm going to go through all the questions that have been forwarded to me and maybe ask some of our participants to ask some of them live. But I'm going to use my moderator's privilege and ask the first question. So, been reading your papers in preparation for this, and your presentation did the similar sort of thing where the course of the research kept opening doors. And from a research, inspiring young investigators, I think from that point of view, it's like you start off looking at a particular activity of a hormone, but things kept broadening in terms of impacts, overlapping activities and things like that. So I think the question is, as you got started, from a research philosophy or strategy point of view, did you start off thinking, this was going to be a hormone with this activity, And then was it the further discoveries that changed your approach and saying, oh, there's so many different doors that will open? I mean, how did you, was that discovery process that you, philosophy that you started with, or did the research kind of like open horizons for you?
So it's the latter, undoubtedly the latter. But you know, I tried to indicate to you, you know, how this all started. It started out from this, you know, kind of gastroenterology point of view, where we had these patients with a duodenal ulcer disease, and we were very interested in acid secretion, and we were very interested in motor control in the stomach, and we were interested in the feedback. We were interested in enterogastrone activity, you know, the inhibitory activities of the distal gut. How was that brought about? So when you get a new peptide, a new hormone, you ask yourself, is this where it has its activity? So this was curiosity, you know. Could it play a role in this? Could it play a role in that? And simply go look for it. And you know, these are the probabilities. And this was also in the period a big curiosity with respect to these new hormones from the gut. You know, people didn't know anything about them. This was completely new. So what do they do, except for stimulating pancreatic enzyme secretion, of course? So this was hugely interesting, and every day was a new excitement, because we went to look for more things and try to see how far we could get. And you know, eventually it got to. So my concept of this hormone is really that its physiological role is to sit there, mainly in the distal small intestine, and regulate food intake and the processing of food, you know, as you stimulate because normally there's no food in the distal small intestine, right? So if the meal is large, then you will stimulate GLP-1 secretion, and it will send a signal to the brain, stop eating, there's enough here. And it will also stop gastric emptying, and it will also stop down the acid secretion and the pancreatic secretion. So it will limit everything to fit the rate of processing in the gut, the digestion and the absorption process. That's what it does in reality. And then it turns out that if you turn up that screw, it can be very, very efficient. And I must say, another inspiration that we've had, which was really, really important, that is bariatric surgery. Because, you know, in these patients, we have tremendous increases in the secretion of GLP-1 and PYY, by the way. Up to 30-fold increases in these individuals. And we and others have indicated, and I still think this is true, that this is really the mechanism whereby people lose weight after these operations. This is the best explanation for that. So you have a model system here that tells you how far we can get. So you can get 25, 30%, maybe 35% weight loss with bariatric surgery. In principle, we should be able to do this with these hormones also. So it's just about finding the right combination.
Oh, thank you.
So there's still work to do.
Oh, yeah, sure. Okay, so let me start going through the list of questions we have. Here's a question. Do GLP-1 agonists have protective effects against bone loss?
Bone loss? So this
Yeah.
is something that we looked at a long time. And, you know, there are some positive reports and some negative reports. And, you know, in general, the effects on the bone are small. And we don't really have the receptors. For that, the GIP molecule is much more interesting, because here you have receptors not only on osteoblasts, but also on osteoclasts. And you can really influence bone mass with GIP. So from that point of view, GIP plays an important role in what we call the gut-bone axis, and it's responsible for the inhibition of bone resorption during meal intake, that is during the daytime. Then it reverses during the nighttime. So that is a really interesting mechanism, but GLP-1 is not very powerful. You know, there are a few positive reports, but the effect is small. I'm not impressed.
Mm-hmm. And no secondary effects through kidney or anything like that?
Yeah, no, not that and you know, again, I have the integrated system to look at, so I can look at these the bone effects, and they're pretty disappointing, I would say. I mean, it's not harmful. It doesn't cause a bone loss. That's not it.
Doctor, can we do this? Can Dr. Di Patricio ask his question live?
Yes, one moment.
Nick, are you there? There you go.
Oh, I'm here. Can you hear me?
Yeah.
Yep.
Oh, good. Yeah, thank you for an amazing talk. This was awesome. So I just have a question regarding development of looking at this from a slightly different angle. So these GLP-1 mimetics are developed. They reach relatively high levels in blood. They're stable and can have, pro-appetite blocking effects as well as anti-obesity effects. Now, what would your thoughts be on development of drugs, for example, that can increase secretion of endogenous GLP-1? And why I'm asking, right? Does it reach a level that is therapeutically beneficial? We know the body physiologically operates this way, but what are your thoughts there?
Yeah, so you're touching on a theme that we've been working on for the last 20 years, because I always felt that to be able to increase the body's own production of GLP-1 was much more interesting. And actually, PYY comes from the same cell. So if you increase the secretion of that cell, you would have both hormones coming out at the same time. And this is exactly what happens in these individuals with after bariatric surgery, that you have this much, much greater stimulation of the L cell and all the beneficial effects. So absolutely, yes. But let me first tell you that the levels of hormones that you are seeing after agonist therapy, they're a little bit cheating because the effective ones, the ones that really count today, and that's semaglutide and tirzepatide, right? They are both protein bound. They're bound to albumin. And that means that you have a big reservoir. So the concentrations are really quite high. There are 20 to 30 to 40 nanomoles per liter, which is about 10,000 times more than the concentration of the endogenous hormone. So this is a little bit of a false picture. It is the free fraction that is the important one. And that is fairly low. It's just perhaps less than 1% of the material that is in the free form, and which is then biologically active and acts on the pancreas and on the brain and all that. So it's not that it is an unsurmountable job to get the relevant concentrations from the natural sources, from the gut. The point is to find the best thing. So we looked a lot at that. So we really worked hard to find out what was the greatest stimulus for GLP-1 secretion after bariatric surgery, and we found it. And you know what it was? It was glucose. But we can't treat obesity with glucose, Christ almighty. So that was a dead end. But then, of course, we're interested in all the other stuff. And there are a lot of mechanisms that you can look at. And one of the things that we're looking very much at these days is, for instance, bacterial metabolites, because, there's a big interest of the microbiota, what they could do. And so we're mapping, and that's a huge undertaking because there are so many metabolites. And it is not written on them which of them are the successful ones. But there's work to do. That's what we do.
Thank you very much.
Great. Thanks, Nick. I'm going to combine a few questions here. One of the things I noted that, especially with the dose response, was that even at higher doses, there's always sort of eventually a plateau of sorts.
Yes.
So I guess the question, whether there's negative effects or other tissues that are affected and things like that. So is there a point when there's actually resistance or some, equilibrium? I mean, what kind of mechanisms take place once you get that kind of plateau?
Yeah. So this is not completely known, and the important factor here is the side effects, because you cannot dial up as you please. You cannot just, move on, because for instance, nowadays it takes up to half a year to up-titrate tirzepatide and semaglutide safely. So you can't just dial up. There's no way of doing that. So that won't work. But it also has to do with the mechanism of action we're looking at here. So what is happening? So you inhibit appetite, which means that people eat less. Because they eat less, they start to lose weight, and they weigh less. And that means that their energy expenditure falls, and it falls and falls and falls until it meets the new reduced energy intake level, so that you now have a new balance. And that's why the curves flatten out, because you've reached this equilibrium between intake and expenditure. So if you want to go further than that, you have to increase the dose further to inhibit food intake even more. That's the only way to do it. And you can do that, of course, by increasing the dose if you do not run into problems with the side effects. So this is a delicate balance. And that's why it's been a little, but you know, some people think that they lose their effect, but that's not the case. And you know that, you can tell, because if you stop the therapy, whoops, the appetite comes back immediately and you start eating, gaining weight again. So there's a good explanation for this feature.
Can we get Dr. Koss to ask her question?
Yes, Georgita Koss, can you hear me?
Yep.
I'm interested in the function in the brain, in the either area postrema or when it gets to the hypothalamus relayed, because it is known that obesity can cause synaptic changes in the hypothalamic neurons that regulate food intake and energy expenditure. Is it known whether GLP-1 agonists can reverse that? And or the other, or opposite, whether long-term use of GLP-1 agonists can cause now other synaptic changes in the brain that would be long-term effect.
Yeah. So actually, a lot of work has been carried out to understand these pathways. And there is actually a considerable literature about the cerebral pathways that are engaged by the GLP-1 agonists. And it is, as I say, the entry point is these organs of the circumventricular organs that then finds neurons that then signal further on to regulate various nuclei in the hypothalamus, and also in nuclei that are associated with the reward system, as I said. And all of these neuronal pathways have been looked at and mapped quite well today in rodents in particular. But you know, the problem is always what exactly happens with people. Can this be directly translated to what we have in people? And here, what we can do is to look at MRI studies that has been done. And they are pretty confusing, most of them, as they always are. But there are some consistencies that are supportive of the regions of the brain where we have the activity. But first of all, you have to consider that it is neurons that are activated in these receptive regions of the circumventricular organs that then signal on to for instance, the bed nucleus of the stria terminalis, and then to the amygdala, and you know, all of these nuclei that are involved, and also to the paraventricular nucleus, and also the arcuate nucleus. That's perhaps directly from the median eminence. And as I said, it's fairly well worked out, but whether you can use chronic studies in rodents and compare them to humans, I don't know about that. I'm somewhat hesitant. At least I cannot see through this, and I cannot tell you whether these changes that you talk about with obesity are effectively addressed. But I think they are, because I think the root cause is being changed here. And the root cause is the obesity and the ectopic fat, which is removed with these therapies. So I think that to the extent that they are caused by the obesity and the ectopic fat, then you can also reverse them. And that would be consistent with the effects of the bariatric surgery also, which I always hold up as a kind of, you know, target for our endeavors.
Thank you.
Thank you. So looks like some of the other questions might have been partially answered. I wondered if you wanted to discuss some of the side effects, long-term effects on some of the tissues like the liver.
Yeah, there are no receptors for GLP-1 on hepatocytes. Let me put that down first here. So there has been publications about this, but there has been publications about anything, you know. So and you know, it takes some time to sift them and, you know, find out what is true and what is not. The agreement today is that there are no receptors on the hepatocytes. That does not mean that there are no effects on the liver. First of all, you have the stellate cells, you have, you know, various cell types from the immune system that may be influenced, as I suggested. And then you have the major factor, which is the loss of ectopic fat, and that includes also hepatic fat. So there's no doubt that you can remove the fat from the liver with these therapies, and that is easy to demonstrate and has been nicely demonstrated in several clinical trials also. The discussion right now is whether you can influence also the inflammation in the liver and the fibrosis of the more advanced liver diseases. And there is a little bit of discussion about that. I still think that if you can step in early and prevent long-standing steatosis in the liver, you can also prevent some of the fibrosis and steatosis, hepatosteatitis from developing. So there's a possibility for prevention, but it seems that full-fledged fibrosis cannot be reversed by these agents. There's a very good and very nice result with tirzepatide, which was published very recently with very, very good effects. But again, the fibrosis was not touched.
Thank you. I was intrigued by you mentioned this again about the anti-inflammatory effects. I mean, certainly in cardiovascular disease, there's an a chronic inflammatory effect. And then when you look at the overlapping effects of cytokines that affect endocrine, hormones, metabolism, is the anti-inflammatory effects, a lot of that is secondary just to reducing the obesity, or are there direct effects in immune regulation?
Yeah, that's a very good question. And again, I think that it is very, very important to include the weight loss as one of the big mechanisms here. But there may be direct effects. One of the systems that I have been particularly interested in is the intraepithelial lymphocytes in the gut epithelium. They carry a huge number of GLP-1 receptors. So it seems that GLP-1 that is stimulated during food intake will activate those lymphocytes. And that means that we have a direct link to the immune system and the inflammation reactions. But my good friend David Drucker in Toronto has really been very active in this field and has done a lot of studies in rodents, of course, about this, and have found that GLP-1s can directly influence a regulatory center in the brain that is involved also in peripheral regulation of inflammatory processes. So I think he would definitely say that there are effects on the inflammatory system also beyond the weight loss.
Thank you. Here's an interesting question. In anesthesiology, GLP-1 drugs slow stomach emptying and increase stomach volume. Can these effects be positively used in patients with abnormal and excessive GI motility?
Yeah, another good question. So this is an anesthesiologist, and usually the anesthesiologists think that you have a problem if people are on therapy with a GLP-1 agonist because they may have a gastric retention at the time when they're about to induce anesthesia. That has been discussed, the pros and cons about that, and the general opinion right now is that there is no additional risk compared to people that are not on therapy, but it's something you have to look out for, because some people have, as you know, may have gastroparesis, particularly in diabetes, and they may have an aggravated effect on gastric motility by the GLP-1 agonist. So once we get into the details here, you have to use your knowledge about the systems and think what might happen. But the intestinal motility is certainly affected very much by the GLP-1 agonists. And there's been a lot of attempts to treat, for instance, in IBD, irritable bowel disease, with GLP-1 agonists. And you can do that. There's no doubt about it. It has profound effects on the various motility reactions in the gut. And this is what explains that some people have changes in their gut behavior. Some people have diarrhea. Some people have constipation. And so these are all direct effects of the drug. And this is something you have to know and live with. And most people don't think it's a major problem, but it explains that why you have changes in your gut behavior while you're on therapy. And it can be used therapeutically. It's just somebody has to do it.
Yeah. Great. Thank you. Are there any other questions? I don't see any more here on the list. I was a little, I was interested in this question relating to satiety. And I guess, you mentioned, well, I guess reward behavior or even addictive behavior.
Yeah.
I mean, in some ways, I was thinking of them as competing pathways, because one would be the metabolic, drive versus actually reward behavior and so on.
Yeah.
Do you see direct links, or are these just like parallel competing pathways?
So right now, the thought is that they are parallel things that are happening, and that not necessarily. This is really for specialists, you know, in these pathways, and there are some wonderful neurobiologists that are looking at this. I would really definitely ask those guys for help here. But as I see it, it's been ongoing for 10 years that people have been focusing now on the reward system, and you know, it's fairly well worked out these days with regions of the ventral tegmental areas particularly involved in this. And Matthew Hayes is the great name in this, okay, the neurobiologist. And so it's been fairly well worked out. And so you have these separate systems, one on the metabolic weight regulation and one on the hedonic weight regulation, and it seems that both are activated. The relationship, on the other hand, to the side effects is an interesting one, because, you know, it's still hoped by some that you can separate the side effect profile from the satiating effect. And that's a question that has not been solved. And there are optimists, you know, that think that perhaps this can be done. Perhaps we can develop an agent that hits only one half of these pathways. But others think that they're so closely united that it's really two faces of the same side.
But we tend to, I mean, medicine tends to be like, here's one drug, here's one target. I mean, if we're thinking of potential for synergies or parallel pathways, has that been thought of?
Yeah. And that is the reason. That is the reason why there is such a huge interest in combination products these days, where you can combine the GLP-1 agonist, which will always, it appears, be a basal therapy for this, but combine them with other pathways. And the best example of that is amylin. Amylin, which has now entered the space also. Amylin was well known, of course, particularly in America, because you had an amylin analog that has been used for type 1 diabetes for many years. But it turns out also to inhibit food intake. And now Novo Nordisk has created a long-acting amylin analog, which is called cagrilintide. And it also has a very nice effect on food intake and by the way, on gastric motility also. But it combines very well with semaglutide. And so with this combination of these two peptides, you have two separate pathways that seem to have an additive effect and maybe a better side effect profile. The same is true for the addition of GIP to GLP-1 in tirzepatide. The GIP on its own doesn't do a lot, but one of the things that it might do is to reduce the side effect profile of the GLP-1s. And that may explain why you can use higher doses of tirzepatide. Typically, you use 10 to 15 milligrams, right? Compared to 1 or 3 or 2 milligrams of semaglutide. That may explain that you can do this because you have this built-in inhibition of the side effects with GIP. That's at least the hypothesis that is promoted these days.
Here's a question. I hadn't thought of this one. Can the satiety state induced by GLP-1 lead to depression?
That is also very good. You know, the big example, of course, is rimonabant, which was used for obesity therapy also, which was a CB1 receptor antagonist, and caused depression and was taken off the market because of suicidal ideation. So that has been looked at very, very carefully in very large materials. And the conclusion right now from 3 very big studies is that there is no increased risk of suicide or depression. There has been some very large studies now. Of course, it's registered studies. It's real world studies, but on psychiatric effects using the usual armamentarium, the diagnostic repertoire, to try to see if you can influence the risk and incidence of any of these conditions during therapy, and it doesn't seem to be the case. If anything, you can see improvements, as you would think, when people lose weight and lose inflammation and things like that.
Sure. Any from the panel here? Any other questions?
I think at this point, I think this has been a really outstanding discussion, and I would like to just really thank everyone who has come and attended this. I just want to thank all of the outstanding discussions, because this has been a really dynamic discussion, really very much newsworthy with what we see on the common news, how it practically affects our lives, how this has been a journey of how science is actually done and discovered. And I think as the talk and the discussion have just done this well. So I thank everybody who asked questions. I thank Dr. Lowe for moderating this. And I thank Dean Dees for leading us in these efforts. But I must, before we thank our speaker, I must thank the Haiders for their vision for so many things, but here their specific vision of the importance of a breakthrough lecture that's always hitting the timely themes that honestly we want to know as individuals as well as researchers and clinicians and educators and students. So I thank the Haiders, I thank everybody, and finally, let us just thank our speaker, Dr. Holst. This has been just a beautiful event, and I just loved your presentation, the discussion, and of course, the very science itself that you've done. So thank you all. And with that, we close and have a wonderful day for everyone here and a wonderful evening from where you're coming from in Copenhagen. Thank you very much.
Thank you. Thank you.
Thank you.
Bye-bye.
Bye.